if they are seeing lumps, bumps, rashes, marks, is there anything that they can do to identify that themselves at home if I can't afford to come and see somebody privately?
If you're checking your moles, ideally you want to do it about once every 3 months. So you don't want to do it every day. That's the other thing. In the same way that you don't notice your children growing up. Other people notice your children growing up. They've not seen them for a few months. They'll say they've changed. But when you see them every day, you don't really notice something changing. And scratching does actually help.
Yeah.
So, I mean, that's why we itch so much. That was our one defence against, parasites and things for the millennia before we had any treatments to use.
Yeah.
You get itchy, you scratch, that kills things off.
Yeah. When it's a sunspot, when it's an age spot, and when it's not.
Okay. Then bingo, you've got a cell that now won't obey any of the rules and it'll start growing inwards.
Absolutely.
You're going to get a skin cancer.
Yeah.
So picking up on these persistent dry bits of skin on sun-exposed sites is quite important.
It is. What is dermatology in simple terms?
It is essentially the study of skin and its diseases.
Because skin isn't just skin. It's your story. And I'm here for it. I'm Kelly Sainer. Are you ready for some barefaced chat? This is Nick Craven, Dr Nick Craven, and or you Mr.
Doctor.
You're doctor, okay. I really want to introduce you to him because he played a really important role in my journey when I was training to be a prescriber, actually. You were my DMP. But he has been a real linchpin in my understanding of skin and given me a real respect for how we should look at skin, treat skin, and how it can just be rogue. It can just do its own thing when people blame themselves for skin things and they don't necessarily need to. So we're going to talk about that. But for those of you that don't know, Nick is a consultant dermatologist with over 25 years of experience, having trained at Cambridge, Oxford and Manchester. But more than that, he's someone I've had the privilege of working alongside at the Regency. At that point in my career, I'd been headhunted to take my clinic in-house. And for the first time, I found myself working in a really multidisciplinary environment alongside a vascular surgeon, and a cosmetic surgeon. So that's when the whole ecosystem of not just aesthetics, but all of those specialities clicked for me and how they were so important. But, at the time, I don't feel like you were just treating patients. You were referring, collaborating, respecting what you could see, boundaries, men, women. There was no discrimination. And that's because it's skin.
That's true. Everybody's got some.
Everybody's got some, if you're lucky. But that's what I found the most fascinating and about your approach to it. So I've been dying to get you on here, as you know, because my PA Sally's been chasing you for weeks and weeks. But as I said, Nick was my DMP during my prescribing qualification. And I always remember how kind, generous and patient you were with me because it's a really daunting space to be in. And skin's really scary because there's lots of scary stuff to see on it.
Lots of things can go wrong.
That's it. And we take it for granted because it's all over us. And we think we've got a bit more.
Yeah.
I've got some somewhere else, I'll be fine. But you never made me feel less than. There was no hierarchy, like I said to you before. Just it felt like there was a mutual respect for what I was doing, and I appreciated that. That's always stayed with me. What I admire about the relationship that you've got with your patients is that you treat everybody as if they're a human, and so many consultants kind of don't always do that. So that's why I think this relationship for me has been a special one because that's few and far between. Especially with my experience in the NHS as well.
Yes.
So, I've got that to compare it to. And then in private land, there might be a little bit more ego at times.
In places.
So, and this is not that, just so you know. So I wanted to talk to you a little bit about the lines blurring between aesthetics and dermatology.
Okay.
More patients turning to the private sector than ever before. The load on the NHS, which is almost making that happen. Because skin isn't just skin. And I say this time and time again, it's people's story. It tells us a story about what's happening to them now, past and future. And there are things that we see every day in clinic that can be harmless or really, really serious. And I don't think people know the signposts and where to go. This is where you come in.
Very true.
It's true. They don't, do they? They're still wondering. They're still left, where who really knows? Do I pay for it, or do I chance my arm and go and see somebody in aesthetics that knows a bit about skin? And it's really tricky. So today we're going to explore dermatology, what that actually is, what it means. I'd like people to understand what the word dermatology means, where aesthetics fits into the picture, how we keep patients safe, and you are going to give us some hints and tips on skin, what to look out for along the way.
I'll try.
Thanks, Nick. Welcome to Barefaced Chat.
It's great to be here. Finally,
Yes, I'm so
finally
pleased.
tracked me down.
Were you daunted by this prospect? Were you excited?
A bit of both. Definitely a bit of both.
Have you listened to podcasts before?
I have listened to many podcasts. I've listened to this podcast as well.
What did you think of it? And what drew you here then?
What
Drew you here?
Well, the fact that you wanted me to come and join you, I thought I'd listen to get an idea of what I'm up against. So that was very useful.
Okay.
But yes, I listen to quite a few podcasts. It's fun. There's loads of them out there.
They're becoming more and more popular, and there's so many different subjects that you can listen to and actually get some quite decent education from some of them now.
Yeah.
Which I love.
Education and entertainment. That's what I'm after.
Yeah, absolutely. I'm getting my son, who's 8, into listening rather than playing.
Yes.
Or watching YouTube and becoming zombified. So they do have their place, and I think there are loads of really decent podcasts that mean well, and obviously some, like you say, they're entertaining. So let's talk initially then about, because I'm just dying to get into this, because we are really going to go left, right, up, down. There's going to be no stone left unturned.
I'll brace myself.
Let me tell you. You've had a really varied career. What was it about? Was it always dermatology? Like what
it wasn't actually, no. When I was a junior doctor in Bradford, a medical rotation was laid out for me. The second job was dermatology. And between you and me, it was a bit of a heart sink moment. I wanted something exciting.
Yeah.
Like cardiology, oncology.
Yeah.
So I went into it with low expectations, and I had an absolutely fabulous time.
Did you?
I saw amazing things I'd never heard of before. And I remember the thrill of diagnosing a skin condition finally by looking at it for the first time.
Oh, wow.
Granuloma annulare, that's the first thing I diagnosed.
That's fascinating.
And it's just amazing. It just stayed with me. I had very inspirational consultants. So it was a teaching hospital.
Yeah.
But not a huge number of teaching. It was mainly, general dermatology being done. And the consultants were just very inspirational. Very, they had time to teach us. They'd take us on the ward round and spend the time to explain what they were doing. It's fascinating.
Makes such a difference.
Yeah, because I did 2 weeks. I mean, most medical students only get a few days in dermatology. We had 2 weeks when I was a clinical student in Oxford. We had 2 weeks, which was quite intensive, but I came away knowing very little practically, which is why I wasn't particularly looking forward to doing the job, because I thought I don't know anything about it.
Right.
And I came out the other end of that 6-month attachment having some idea about what it was, but also realising that it was just absolutely fascinating.
Oh.
So from that point on, I was pretty clear that's what I wanted to do.
That's incredible.
Yeah.
Do you know what? It will have made the difference, that one teacher, that inspirational teacher.
It's very true.
There's always
very
something
true.
that keeps you in. It's got to keep you hooked. And if somebody believes in you and inspires you to do something.
And you get a bit of positive feedback when you get something right. That's very nice.
That's amazing. So I can see that, though. That's a really interesting take on it. The sort of glitz and glam of cardiology and and that sort of the quick wins of being able to save somebody's heart must have been quite seductive. Whereas actually for you, I'm sure most start off thinking skin. Okay. But obviously wow, what a difference.
Yeah.
Amazing.
So it was the variety of things that I found thrilling rather than the tempo at which it had to be done.
Yes, exactly right.
Yeah.
And that
suits my personality.
Absolutely. I completely agree with that. I'm the same, 100%. For people that are listening or watching us have a chat right now, what is dermatology in simple terms?
It is essentially the study of skin and its diseases. So it covers pretty much everything.
But this is
about three. I think there are over 3,000 different skin conditions. So I've not seen them all, and I'll never see them all because there's a lot of small print. But the variety is enormous. And most weeks I will see things that I've not seen before. I see things that I saw maybe 10, 15 years ago, which is great because now I've recognised it.
Yeah.
And so there's endless variety. And not only, I mean, for each given condition, there are many different ways of treating it.
Yeah, that's right.
Many different things you may have to do to confirm the diagnosis. So it's just endlessly fun. It's like detective work.
That's what's great about it.
3,000 different crimes to solve.
Don't you think that people think that you should know all of them? Some people.
I guess some people do. I manage to blag it most of the time.
Brilliant.
While I'm thinking.
Of course you're,
in the background.
Absolutely. You have to pull it out the bag. I mean, that's part of our job, isn't it? To be able
Look
to
confident.
Pull out what you can.
Yeah.
Go through the back catalogue. Think, have I seen this before? Make it work,
One useful thing about using a dermoscope.
Yes.
Because it gives you time to, while you're looking with one eye, you're thinking with the other.
Yeah. Love that.
So,
exactly. Yeah. You know the dermoscope then? Can anybody buy those? I'm being facetious, by the way.
Yeah.
I mean, but we're not the layperson isn't trained to look through a dermoscope, are they?
No. It takes a long time to start to understand what you're looking at.
Right.
You see a lot more. The analogy I use is if you look at a stream, just looking at the stream, you'll see there are things. You might see things swimming down there. You'll see rocks and bits of weed. But if you put on a pair of goggles and stick your head underwater, you're going to see a huge amount more.
Yeah.
And that's exactly essentially that's what a dermoscope does.
Okay.
So you've got to learn everything now that you're looking at. And dermoscopes were just kind of coming into play when I was a registrar in Manchester.
Ah, okay.
And I went on a course on dermoscopy in Austria, kind of halfway through my training, and loved it.
Wow.
Got myself a dermoscope, and I've had a few since then, and I now couldn't function without them.
Okay, for those that are practicing in dermatology that don't use it, and can you still do the job without using it?
I doubt it.
Right.
I don't think so. I don't think these days any dermatologist is going to be
without one.
Going to be turning up without a dermoscope.
Okay. And when we're talking about that magnification that you're getting or that ability to see beneath, what are you actually, could you explain what it looks like naked eye to through a dermoscope?
Well, if you take your average mole,
yeah,
so brown mark to the naked eye just looks like a brown mark. When you look at it with a dermoscope, you're going to see potentially network, so pigment network, fibres of pigment going in different directions, or you're going to see globules of pigment. And when you can see that detail, that's when you start to pick up when actually this mole doesn't look right. This network doesn't look like a normal network.
Yeah.
And so there are certain things that you look for in a melanoma, different colours, odd things, bits of network looking unlike other bits, just a kind of chaotic variety of what's going on. So you need to see lots of normal things to then start to get a good feel for the abnormal things that you see.
I see, absolutely.
So it is something that you kind of learn gradually just by using it all the time. So I started off looking at all moles with a dermoscope. It just adds to your kind of mental memory bank of what normal looks like.
And you've got to understand normal, haven't you, to, like you say, understand abnormal.
And even if you don't know what you're looking at, if you know that it doesn't look normal, then that's a red flag. Okay, so I don't know what this is. So am I going to monitor it, or am I going to biopsy it, or am I going to cut the whole thing out?
Why don't you just go, if it doesn't feel normal, why do you have to make one of those three decisions? Why can't you just say, it's coming out, it doesn't look normal to me?
So, well, that is one of the options you've got, but it depends. Not all things are pigmented lesions, so sometimes you may be looking at a rash, in which case you're just going to biopsy a small bit of it.
Yeah.
Some things may be flat, looks a bit odd, but in some cases it's safe to monitor things. If something isn't changing, even if it looks abnormal, as long as it's not changing, then it's behaving in a benign fashion.
Yes.
So you've got to make a judgment as to, is it safe to kind of watch this for a period of time?
Yeah.
If it's safe, is that the appropriate thing to do? Is that what the person wants?
Yeah.
Someone may be dead against having surgery.
Yeah.
So I'd say, well, okay, well, I think it's reasonably safe to monitor it then. On the grounds that if I'm not happy when you come back, then I'll twist your arm and we'll have to remove it.
Yeah, I like that.
So that works.
I think that gave me a really interesting perception on what I was seeing, and not to knee jerk into things as well. I think very quickly as medical people, because our MO is to heal and treat you and to get you the resolution that you need or whatever. And it's quite intimidating sat in front of a patient when you've got knowledge and some power that you don't just want to fix it. And actually, it really taught me to just hang fire when we worked together. And that watchful wait.
Yeah, it's useful.
Yeah, really useful. So I think that's something that lots of people need to just take into consideration. Some people either act on it very quickly, very anxious, need to know, and then other people are prepared to say, well, let's just see what happens. People do it in daily life.
Yeah.
But I think when you get told it by somebody like a dermatologist or an aesthetic specialist, you might take it a bit more seriously. So it's always been useful for me whenever you told me that. I use it all the time now.
I tell you what, one of the most fun things to do with a dermoscope is to diagnose scabies.
Oh.
Because there's a lot of scabies around at the moment.
There is, yeah.
Huge amount. And there's a lot of resistance to treatment, a lot of resistance of the mites to the things that have been used for a long time, I'm finding.
Go on.
And when people turn up, they are quite resistant to having a diagnosis. So with a dermoscope, I can attach a camera, take a photograph, and actually show them the mite,
That's
great. Then reinforces the need to treat themselves. Because you've got to be quite thorough with treatment.
Do you know, somebody came in a couple of weeks ago and we did a very, very basic early diagnosis of scabies. We couldn't believe our eyes. Why has it come back? Why is it so prevalent?
That's difficult to know. It does tend to go in cycles.
Yeah.
I was told as a trainee that every 7 years or so you get you tend to get a mini outbreak. This has been quite a maxi outbreak, to be quite honest. It's been going on a couple of years. And still seeing people who have, where the diagnosis has been missed and so it's kind of progressed. People where I suspect that not everybody's being treated, so they keep catching it again.
Yeah.
And I think people genuinely where the treatment they're using just isn't working.
What's the common misconception about scabies?
That you can wash it off. That because you've got it, it means you're dirty. It's not at all.
I hear that all the time.
You can't wash it off
once
it's established. Also, the other thing is the mites don't really survive long once they come off your body. There's only rare cases, crusted scabies or Norwegian scabies, where people either don't itch because of some neurological deficit or they can't scratch. Scratching actually does reduce the number of mites. This podcast's gone rather dark, hasn't it?
I love it. I'm like, we've not talked about scabies before.
Scratching does actually help.
Yeah.
So, I mean, that's why we itch so much. That was our one defence against, parasites and things for the millennia before we had any treatments to use.
Yeah.
You get itchy, you scratch, that kills things off.
Yeah.
And that was actually quite effective at keeping numbers of mites under control. And people who can't scratch, you can see they get absolutely covered. Oh. It starts to look more like psoriasis. They get sheets of kind of scale which are teeming with mites, and they're very contagious. So you can catch scabies off them quite easily from the dead skin in their environment. But most people with scabies have only got a dozen or so mites on the skin.
Why is it making me itch? It's like talking about.
So I caught scabies when I was a registrar from a patient who was admitted. Yeah, a patient who was admitted with bad scabies. Diagnosis hadn't been established. We all went in, examined, and a few days later, I saw the burrow starting on a finger and working its way up the finger. And suddenly it dawned on me what this was.
Oh my goodness.
And now every time I see someone with scabies, about an hour or so later, I get that tingling.
Do you?
Yeah.
That feeling.
It's feeling. And I presume it's an immunological thing. I must get proteins on the skin that my immune system recognises, and it just makes me itch.
Wow.
I know.
Oh my goodness me. I love this. This is one of the. This is going to be brilliant. The dermatologist that caught scabies with patient.
I think it's an occupational hazard.
Oh my goodness me. I mean, I'm sure that's happened before, But
Well, I hope so. I hope I'm not the only one.
you're not the only one. No, it will have happened.
But
It happened hundreds of
you
times.
see, one of the things I was told when I first started is it's not a great idea. It's not a great look to put gloves on to examine your patients.
Really?
And I agree with that entirely. If you're gloving up to look at someone's skin, that gives them a message that they're contagious, dirty.
Yeah.
So I'd never do that.
Oh, that's so interesting.
I'd put them on to operate.
Yeah.
Because I need to be sterile for that, for their protection.
Mm.
But I wouldn't put them on to examine.
Right.
Unless it's, an intimate examination, in which case it's only fair.
Absolutely.
Yeah.
But
anything else would be wrong. But for general examination, no gloves.
See, in this land, because we're seeing so many people and that the turnover.
Washing my hands instead.
But the thing is, I think because we're touching skin daily and we're doing treatments that are we're wet, we're dry, we naturally glove up. I prefer not to wear gloves when I'm doing examination, but I will ask patients now and I'll say, I'd prefer not, but how do you feel? And some people are like, no, I'd prefer you to wear gloves, please. I don't know where you've been. But otherwise, it's much easier. It's like a surface between you and the patient as well.
So. Because it's not all, a lot of dermatology is visual, but a lot of it is also palpating what you're looking at. You can't do that properly with gloves on.
No.
Not with skin things.
No, you need to be able to be close to it.
Feel it.
You need to feel the
stretch
scabies.
it. Yeah. It's not, a lot of people think that sending a photograph is as good as seeing someone in person. It's not at all, because when you're seeing someone in person, you're looking from different directions. You're using the light in a different area.
Yeah.
Get your dermoscope on it.
Yeah, I love that. Oh, I think that'd be really interesting to take to children as well. Show kids, actually, wow, what can we see through this really, really clever instrument? I think that'd be fascinating for them. Anyway, talking about that then, in terms of people coming to see you, before we get into sort of the blurred lines between aesthetics and skin, I really want to go into dermatology land a bit deeper, if that's all right. Give people sort of a little bit of armoury that or a little bit of confidence. If they are seeing lumps, bumps, rashes, marks, and we go to the GP and we get told, because unfortunately the NHS dermatology waiting list is like 13 weeks.
12 months.
12 months.
Plus.
Wow.
I know. Even after you've been seen, waiting for some operations is another several months.
You've got a different skin. That's nuts.
I know.
I didn't realise it was as long as that.
Yeah, it is months and months and months.
Okay. Those that unfortunately can't afford to see you, go to their GPs, go to dermatology, sit and wait. What if they're sitting and waiting with what looks to them like a raised, itchy, something that we might know as some sort of keratosis, actinic keratosis, seborrheic, whatever. Is there anything that they can do to identify that themselves at home if I can't afford to come and see somebody privately? How do I get myself out of trouble or away from worrying without speaking to Dr. Google, but being able to look at a lesion and think, is it something that I'm okay to wait with, or I have no choice but to wait with?
First of all, it's difficult, but there are a couple of things that are useful pointers. There's something called the ugly duckling sign, which is a kind of concept that I use when I'm looking at people's moles. If someone's got, 200 moles, if 199 of them all look the same, then I'm not worried about those. If one stands out very much from the background, that's the first one I'm going to look at.
Yeah.
Because if you're unlucky and you develop a skin cancer, it is going to change. Their behaviour is chaotic. Benign things behave in a very controlled fashion. They may end up looking rather ugly, but their behaviour is kind of controlled.
Got you.
So a mole is going to grow pretty much evenly in all directions. So it's going to end up round or oval because it's easier to grow in certain directions along the skin than in others. So often they're oval. And it'll either be smooth or it'll be dome-shaped. Okay, so it's doing everything pretty much the same in all directions, whereas a melanoma will be behaving in a chaotic fashion. So the longer you leave it, the more it looks irregular, the more it stands out from everything else. So there's two things there. There's if something is standing out from everything else, then that's the thing you worry about. And if something is clearly evolving,
Yes.
whereas everything else isn't, then that's also something to get checked out. And then the other side of this is that there are plenty of completely harmless things that look fairly ugly.
Yeah.
Seborrheic keratosis is one thing that you mentioned. They're very common. They're pigmented. They build up a lot of dead skin on the surface and they can become inflamed. So they can do things that are a bit worrying, but they will often then settle back down to how they were before. So you're looking for progressive change. Things that are painful, things that are bleeding, things that are crusting, things that behaviour is different to everything else, not necessarily just appearance. Those are the kind of things.
How many times have you seen somebody ignore that can afford to come and see you, that ignore a mark and it's just got worse and worse and worse? Have you seen that quite a lot?
Oh, frequently.
Yeah, I can feel
frequently. That. So in many cases, most of the pigmented lesions I look at are perfectly benign. And people are understandably a bit worried because they may have become inflamed or they may look a bit different or it's a new thing. But once you've seen many, many moles, I'm quite comfortable at reassuring people that things are benign. But then sometimes I see things that I think that looks so different to everything else.
Right.
You know, someone who's looking at their skin, I would think they would have recognised that looks absolutely, completely different to everything else on the skin.
Yeah.
And those are the kind of things I try and encourage people to look out for. So the current guidelines are, if you're checking your moles, ideally you want to do it about once every 3 months. So you don't want to do it every day. That's the other thing. In the same way that you don't notice your children growing up. Other people notice your children growing up. They've not seen them for a few months. They'll say they've changed. But when you see them every day, you don't really notice something changing. So looking at your moles every day isn't great because you may not realise that this thing is actually evolving. So actually pausing, taking a look every 3 months, that's thought to be the best interval.
Love that.
If you leave it 12 months, then you might have missed the boat by then.
Yes.
In most cases with melanoma, you haven't missed the boat. In most melanomas, you can cure just by cutting them out.
Okay.
But you don't want to put yourself in that group where it's getting a bit dodgy, a bit thicker, a bit more liable to have spread before it's removed. So checking every 3 months is a good thing, good habit to get into.
Why has melanoma got such a bad reputation for sort of this majorly, if I get it, it's going to kill me, as opposed to like a very basic BCC skin cancer that some people hear the word cancer and go, oh my God, I'm dead, regardless of what that could be.
Yeah.
I think the difference between a BCC and a melanoma, the melanoma is
completely different.
Completely different, far more sinister.
Yeah. So basal cell carcinomas are very common. They are more common than all other cancers added together.
Yeah.
And they don't have to be reported. So they are underreported.
Yes.
Yeah. And I will often pick up basal cell carcinomas looking at someone who come along for some other reason.
Yeah.
It's not they're there frequently turning up.
Yeah. And
then it's just a question. I reassure people that on the whole, they're just a nuisance. They need removing. If you leave them, they'll just keep on growing.
Yeah.
They'll grow. If you neglect it for decades, it can grow through bone if you leave it long enough.
Yeah.
But, if it's there, just get it cut out and that will cure it. Melanoma is the other end of the spectrum. They can metastasize unless you cut them out reasonably early. And once they've metastasized, trying to get that cured is a stepwise change in difficulty. And they are, they're on the outside pretty much. Most melanomas are on the outside. If you're keeping an eye on your skin, you stand a reasonable chance of picking it up sooner rather than later.
Right.
But they disproportionately affect younger people.
Yeah, why is that?
I think it's something to do with biology of, first of all, they're on the outside. Melanocytes are in the skin.
Yeah.
And if you go and get sunburnt at the age of 3,
absolutely,
then 10 years down the line, if you're unlucky, if that sunburn has caused a critical change in a melanocyte,
absolutely,
which then starts to grow, it normally takes 10 years or so for a melanoma to start. If you get burnt as a teenager, you're going to potentially have skin cancer in your 20s or 30s. Unlike basal cell carcinomas and squamous cell carcinomas, which tend to take a lot more sun exposure to cause them.
Yeah, and that's why we see them a little bit.
You tend to see those in older people.
Yeah.
So melanomas, the incidence of melanoma increases as you get older, but it's actually quite a high incidence in young people. So it disproportionately kind of appears in the news because you hear stories of young people having melanoma removed or even,
Absolutely.
regressively dying of it.
Yes, and that's the thing I think that scares people. I think it's got this real reputation for being a real sort of killer,
Yeah.
unnecessarily so. Because
Yeah.
I think people also don't want to admit excessive sun exposure, hadn't appreciated when they were younger because the education wasn't there.
Yeah.
Either, our parents weren't putting sun cream on us because they thought that they were going to protect us from potential melanoma in the future. So I think there's loads to unpack there, but I think it's a real risk and a worry, especially with the rise of the sunbed era as well. That exploded a number of years ago. It's becoming less so now. It's not as fashionable anymore. But yeah, I do think there was a major issue. And the feeling of that, I get loads of people talking to me about it and really worrying, particularly about that cancer.
And it is important to get some sun exposure. We rely on the sun largely for vitamin D. You don't get much of that through the diet. And if you're vitamin D deficient, that has all kinds of other knock-on effects on you.
There was a massive rickets epidemic in Ireland.
Yeah.
Not that long back. I was amazed.
Yeah. So you need a bit of sun exposure, but people still like to look tanned.
Yeah.
And that's apparently, I was told, all down to Coco Chanel. When she was promoting her range of cosmetics, she created the kind of French peasant look. This outdoors look. Before it used to be if you were tanned, then you were probably an outdoor worker.
Yeah.
You weren't very wealthy.
That's right.
All the rich people looked pale.
That's right.
And then she flipped that completely.
Well, that is why in the more Asian and more sort of Eastern hemispheres, glutathione, this is my favourite ingredient, is huge because of its by proxy whitening ability.
Yeah.
So because of that sort of, unfortunately, still steeped in a little bit of heritage out there, the caste system,
Yeah.
I think that was a massive, I think that's still why it's still got some prevalence today. Anyway. So yes, the melanoma thing is a biggie, a big deal. But one of the things that patients talk to me about a lot, Nick, is this, do you think, can you have a quick look? Do you think I should go? Who should I go to? Can you recommend? What does it look like? It's not changed. It has changed. Can you do more mapping? All of the things, because the accessibility to dermatology is so rubbish.
It is.
That we need to really get more dermatologists, people more access to dermatologists on a day-to-day basis.
Yeah.
Because we've got skin, it's our biggest organ.
It is.
And the NHS just do not appreciate that.
I hope you're not going to ask me how we do that, because I've absolutely no idea.
Come on,
absolutely
I want your thoughts.
No idea.
I mean,
you've got to train them up.
Yeah.
And it has to be a priority. It has to be a priority for those, in the health service, those in government who set the priorities.
Yeah. It's just, it frustrates me. And not only that, but, even down to all the denominations of skin, like, acne. Obviously, I see a massive gamut, but in a very different way. I see some of the before and afters of yours. Teenagers with acne, menopause women with acne, young boys with acne, not acne scarring, ice pick scar, but in the middle of that, just so many different conditions that need a dermatologist. Not me. I know where my limitations are, but I know that I can do so much because I made it my business to understand how the skin behaves and the physiology. But, where you're concerned, it just drives me bananas that we don't have this service. No. We don't have loads of services, but this is a big service.
Yeah,
it's
to us.
Huge.
It is to us. I mean, we appreciate it. Not many people appreciate it.
No, I guess so. But yeah, it covers so many different things people are living with daily, and it just, it's really annoying. Anyway, can you explain to our wonderful listeners in simple terms, because I talk about basal cell carcinomas all the time.
Right.
I mean, it's not like fashionable or anything, but
everybody wants one.
Everyone's kind of, this epidemic of bloody Epidex that people are getting from the GPs. I'm seeing in 1 in every 3 patients. It's ridiculous. I've got this cream. He's given me just because I've got a little. He didn't tell me though my skin would be awful after. Or she.
something I think you have to do that when prescribing this 5-fluorouracil. It's a chemotherapy agent, and it's going to kill off the abnormal skin cells that it finds on the outside, and it's going to make a mess. So if you're unlucky and you get an internal cancer and you have chemotherapy, you feel awful. It's having that effect internally.
Absolutely.
And your body's having to get rid of this stuff. With topical chemotherapy on the skin, you can see what's happening. It feels a bit awful in that area. It doesn't usually make people feel systemically unwell. Sometimes it does, but not often. But it does look awful. And I always show people pictures of what they're going to experience while they're on it. Otherwise, they just think they're reacting badly to it. They've got to be prepared.
You care.
Yeah. Well,
and actually,
yes,
you know when patients come back.
Yeah.
And they're alarmed.
Yeah.
And you're trying to mitigate a little bit of that and set their expectations. GPs haven't really got time for that.
No, and they probably don't use a lot of it.
No, true.
So I always warn people, it's an awful treatment to use, but you'll love the end results. You just got to knuckle down, find a time of the year when it suits you to do it. Get on with it and do it, and you'll be happy afterwards.
We all need a Nick, don't we? Just come and live in our house and show him all your bits. Sorry.
Not all of them.
It's turned into an entirely different podcast. What's the difference between sun damage, allantogyny, solar keratosis, all these different names? Obviously, I'm aware of this, but it's not my podcast, it's yours. You've got much deeper knowledge of skin from that side. Okay. So I'd love my listeners to and you can obviously share this as well, because I think it'd be fascinating for people. What when it's a sunspot, when it's an age spot, and when it's not?
Okay. Sun has many different effects on the skin. When you go outside in the sun, your skin, any exposed bits, are being hit by ultraviolet. So ultraviolet photons are hitting the skin all the time, and they have enough energy to damage whatever they hit. So they're going to be absorbed by something. And the energy in an ultraviolet photon is great enough to structurally change the thing that it hits. So the rest of it then is down to good or bad luck. So if it happens to hit DNA, it can cause damage to the DNA. Now, most of the skin cells on the outside have a lifespan of less than 4 weeks. Okay, it's constantly replacing itself. This is probably why, because there's lots of damaged skin that's gone in a couple of weeks. Yeah. But there's the basal layer, which is always making all the other cells. And if you're unlucky and the photon misses all the other things and lands in a basal cell and lands in a bit of DNA, just in the wrong bit of DNA, and damages it, then you're relying on your cellular mechanisms to repair that. And it's clever. They're enzymes that zip along DNA, finding little bits of damaged DNA, snipping them out and repairing it, knowing how to repair it by looking at what's going on the other. It's a double strand. Yeah. And what I found, one of the fascinating things I found out was the snipped out little bits of DNA. It's reused. It's a chemical that tells melanocytes to start producing pigment. Yeah. So we tan. Yeah. When you go outside, you're tanning because your enzymes have found bits of damaged DNA, they've snipped it out, and those snipped out bits of DNA tell the pigment producing cells to turn on. You've damaged your DNA. If that repair job was 100% successful, would be great, but it's not. Every now and then, a bit of DNA is repaired wrongly, and then you've got a mutation. So if that mutation is in a cell that's going to be there for the rest of your life, then you've got kind of one notch. Cancers usually need a few DNA bits of damage to start misbehaving, which is why we're not sprouting up in skin cancers all the time. But it's just a series of accidents in the same cell that then allows that cell to start misbehaving. Yeah, that's right. Okay. Now, how it misbehaves depends on what you see. Yeah. So if it's one of the keratinocytes, you're going to get cells that are just growing a bit abnormally. They're not evolving properly. The dead skin on the surface doesn't separate away when they reach the outside. Your immune system realizes there's something going on and it diverts blood there to try and keep it under control. And so actinic keratoses, which are very common bits of superficial sun damage, They feel rough because the dead skin builds up on them. And they often look a bit red because the immune system knows that there's something going on there and it's trying to keep it in check.
I'm geeking out.
Yeah,
I love it.
So these are lots of little bits of accidents that happen. And if you get loads of actinic keratoses and still keep going out in the sun, you're just asking for trouble because you've got a clone of cells with maybe 1 or 2 mutations in. If one of those gets a 3rd mutation, then bingo, you've got a cell that now won't obey any of the rules and it'll start growing inwards.
Absolutely.
You're going to get a skin cancer.
Yeah.
So picking up on these persistent dry bits of skin on sun-exposed sites is quite important.
It is.
Then you get the solar lentiginous, where the effect of the sun is basically just to cause a localized area of cells to accumulate more pigment. They're perfectly benign, but they all tend to look like each other.
Yeah, that's
so solar lentiginous look that kind of mottled freckling that people get, often on the shoulders, on the upper back, upper chest, if they've had a lot of sun exposure.
Yeah.
It's a bit bewildering, but when you're looking at someone, I tend to kind of blank all those out. If they all look the same, ignore them. Concentrate on the things that look different.
Yeah.
They're the things that you kind of need to be looking at closely.
Oh, Nick.
So there you go.
It's just like heaven to me. No, it is, because it's compounding some of the things that I talk about every day. And I just think it's really nice to be able to geek out with somebody that knows what he's talking about. Honestly.
Thanks.
I'm totally nerding out.
No offence taken.
Okay, so given the lack of access to dermatologists in the NHS, we know the only way it's going is down the private route. People are accessing aesthetics practitioners like myself, other colleagues. We don't know anything anywhere near as much in terms of, because we've not been trained. Thank you, of course not. So unless you take it upon yourself to do a course or understand it in a different way, and I talk to my practitioners that I train in the Perfect Peel and things about this. Why get involved in skin if you don't know anything about it? And we're not just talking skin, like you've said. There is so much going on. You need to know each layer, the behaviour, why it's different. There's so much that we don't know as well, especially where pigment's concerned, because of all the other stimulus that's going on hormonally and throughout your entire life. And I've come to the conclusion, I am getting to my point, is that, and that's why I formulated this particular skincare range, is that we're always dealing with, whether you're 18 or 18, I'd love to get your take on this, dealing with 3 different issues. Pigment, red or brown, and everything in between. Lipid quality, dry or oily, and everything in between. And then texture, rough or smooth, and everything in between. It feels like those are the 3 things that I'm hearing over and over again, and everybody is dealing with those in differing levels, or all, or not, or what. Does that make sense?
From an aesthetic point of view, yes.
From a skincare perspective.
From a skincare point of view, yes.
Do people come and see you about skincare stuff?
There's certainly some overlap. I think they expect, because I'm a dermatologist, to be an aesthetic practitioner, which I'm not. And I think that may come from, in America, there are more dermatologists in Miami than there are in the UK. Okay, there are dermatologists everywhere. So they tend to branch out and they tend to do a lot of aesthetics. In Europe, dermatologists, there are many dermatologists there, they tend to branch out into venereology, to use its technical term. In the UK, we don't have many dermatologists, so we all tend to just stick to doing the dermatology. So there's a lot about aesthetics that I don't do. I remove benign moles if people don't like them. I remove plenty of benign things if people don't like the look of them. So in a sense, that is aesthetic, but I don't think that's what most people think by aesthetic dermatology. So yes, they will often ask me, and if I'll tell them what I can tell them, and if I don't know what I'm talking about, I'll send them to you.
Yeah, and vice versa. That's what's great about treating and I loved learning about the Roaccutane, methotrexate, all of these things that are being used and being prescribed daily, and can really have got quite profound effects on patients and side effects.
Huge numbers of new drugs coming online for the people with more difficult inflammatory skin conditions. So the number of ways now of treating psoriasis and atopic eczema, it's just changed. The landscape has changed completely since I started out.
Yeah, I can imagine.
But they've got to see a dermatologist. They've got to get to see a dermatologist, and it usually has to be NHS because the new things are really expensive. The old things are much more affordable, although there's a lot of monitoring required. So yeah, it's constantly, the landscape is constantly changing.
Well, I mean, it does. We were over at part of Medica Forte teams moved to Alderley Park, and there's loads of drugs there, skin drugs, that were being tested and used. And there's a list of all of the new ones coming out and when they were first brought to market. It was fascinating, actually. But yeah, it just reminded me of when you said that. Okay, let's go back a bit. Lots of my colleagues talk to me about, and the people that I train talk to me about different skin conditions of people that are approaching them and not going to a dermatologist because they can't afford it. Some of my colleagues have been known to try to treat or diagnose whatever, quite aggressive skin issues, rashes, goodness knows what, and it's really irresponsible. But these patients can't afford to do anything else.
And it's very difficult to know what the answer to that is. I think in many of the larger GP practices, there will be a GP with more skin experience than others. So finding the right GP sometimes helps. GPs will often develop interests in various areas. So there'll often be someone with an interest in skin, others with an interest in, women's issues, others with, care of the elderly, those kind of things. Yeah. So often finding the right GP helps. Pharmacists are expanding their role, and they can see and advise and prescribe a limited amount of things.
Yes.
But it's difficult. I mean, dermatology is difficult. I find it difficult still. I see things that I don't recognise. You have to know, I guess, when you have seen a lot, you then start to realise I'm looking at something really weird because, I've been doing this for 30 years and I don't know what that is. Yeah. So and then you've got to have a strategy for figuring out what it is.
Yeah.
People who don't do it all the time, it must be bewildering.
Yeah, absolutely.
So on basic principles, if dry things are dry, moisturise them. If things are wet, try and dry them up. Old-fashioned potassium permanganate soaps are useful for wet, weepy eczemas. Yeah. If it's infected, treat with antibiotics. Yeah. If you've excluded infection and it looks inflammatory, then try a topical steroid. There are lots of basic treatments that will work pretty well for most things. Yeah. But if something's not responding to treatment, that's when you need to get help, get someone else. Don't give someone something that you think is going to help and then say, go away.
This is the thing. This is the worrying thing.
You need some kind of backup, which I'm sure, experienced practitioners would do. If this isn't working, come back because we'll need to think again. I do that myself.
Well, absolutely. Part of what I do teach is because I found your help invaluable, and we work together through the prescribing reasons, but having spent time with you on the more serious things, I always encourage practitioners to buddy up or at least find a dermatologist that they can refer to so they understand their limitations and where they should say, no, this is beyond my pay grade. This is beyond my level of knowledge. I need to send you to somebody else. And they're not doing that. They're trying with a steroid, or they're trying with fashionable, tret. They're trying to treat and manage these conditions that I just don't think that they're able to manage because it's beyond their scope.
Yeah, you've got to be careful. I mean, that's why any consultant in dermatology will have their plastic surgery buddies where they're going to send things that are, beyond our surgical skills. Many things are beyond my surgical skills, so I refer a lot of things onto plastic surgeons, using all kinds of different specialists. So yeah, it is important. If you don't realise your own limitations, you're going to get caught out.
Massively, but that's a big worry in aesthetic land, especially because of the lack of regulation. So we're seeing more people because of the privatisation or the lack of service within the NHS. So things are moving more private. They've got less accessibility. Then people are going, there's more aesthetics clinics popping up, claiming to be able to be skin specialists, which is, that's you as far as they're concerned. They're a skin specialist. And it's like, and only because I've got the knowledge, had the years of experience. I've been doing this. I've been nursing 7 years, whatever, and in aesthetics for 21. You know, it's only because I've bothered and I give a shit and I want my patients to get the best possible outcome. And if it's not me, I am not precious. Go and, you know, I will refer out, but loads of people don't. And it's a massive worry. Anyway, I just think
it's a skill to learn. You have to learn how to refer someone to someone else.
True.
Without, you know, coming across that I've no idea what I'm doing.
Very true.
It is, you know, there are ways of saying I don't know what I'm doing here. You know, I've done everything I can. And it's nothing to be ashamed of. Everybody refers on to other people.
It's important, isn't it?
It is important.
Because it's talking
otherwise
about...
you keep on getting it wrong.
Exactly.
But you don't know.
That's the point of a multidisciplinary team, and that's what I say to my patients as well. There are lots of people, you know, it takes a village and all that, but there are lots of people that are very good at understanding their different denominations. I'm amazing at this, this and this and this. I think I'm pretty good at it, but this is where I think I need another pair of eyes, my specialist Nick friend. And off I send them to the Spire. You know, when you... left NHS work to work privately. Did things then, was it just a big sigh of relief without wanting to diss the NHS because it gave us our start, you know?
It did.
Was it just a real sort of, this was where I was going?
There's the concern. I mean, NHS is a kind of safety net, not just for the people being treated, but the people working in it, because they don't look after you very well, but they pay you.
Yeah.
You've got quite good terms and conditions.
Yeah.
And severing that is a bit of a bit of a gulp.
Yeah.
Am I going to be able to do it? What if no one wants to see me?
Yeah.
So I took a while to come to the decision, but I had colleagues at the Nuffield saying, just do it.
Yeah.
Just, if you're fed up of it, which they could tell I was, because I would go in whinging, just leave. Come and work here all the time.
And you did?
And so I thought, all right, eventually.
Well, great.
I decided, yeah. So
Best decision?
I think so, yeah. Because I would not go back.
Okay, I think that's
I wouldn't
the
go
best
back,
decision.
no, not at all.
Not even if you were paid the big bucks.
No, because you're then working to someone else's idea of how you should run a clinic, and I don't like doing that.
Love it. That's music to my
But
ears.
I don't think you can rush it. I don't think if you're only given 15 minutes for a new patient, to me, that may be long enough if they've got a mole that's benign. But if someone turns up with a weird rash, it's going to take longer than 50 minutes to sort them out. And you're doing that over and over again, and it just kind of builds up. That's my opinion.
I agree.
And
I absolutely
I'm
agree.
proud of it.
That was, well, I'm pleased because that's why I left. I remember being at the Harley Med. I remember being it's different in peds. It was a different environment. But when I was at the Harley Medical Group and consulting for cosmetic surgery and doing treatments and charging a lot of money, I would always be the one. I mean, you know, I like to talk.
No.
But it would always be like, taking your time. It was that day I thought, I want to do this for myself.
Yeah.
I need to give my patients the best and the time.
Yeah, exactly.
And
because that's probably the only way you can keep on enjoying the job.
Exactly.
If you can't enjoy what you're doing because you're under constant pressure and you can't do a decent job, what's the point?
I agree. What is the worst or the most aggressive something that you've seen? And in dermatology, as your speciality, because you said you diagnosed lots of things as well, have you, because we don't really link in the same way dermatology to death, if that makes sense, because it's not, it's a bit slower than that. You know, if you get diagnosed with a, you know, lung, liver, whatever condition, you go through sort of specialist treatment. We don't really see dermatology like that because of the variety. Just for gruesome, twosome stuff, like just so people get a feel of like the reality of what your job is. What's the most aggressive thing that you've seen, like textbooky stuff?
Okay.
Because I remember being on a paediatric ward and seeing a patient with a young child, family actually, with head lice.
Okay.
It was
Aggressive head lice.
In fact, it was on the car. It was actually everywhere, on all the clothes, in the cardigans, in the ears, brow, like they'd lost hair. It was bad.
It was bad.
Bad enough to be photographed.
Right, yeah.
And textbookized.
Yeah.
Textbooked. So yeah, I was going to throw that back out at you because I
most
think this
aggressive
is
thing.
quite interesting.
I think the most aggressive condition that I've had to deal with is a type of drug reaction.
Oh, really?
Yeah, it's called toxic epidermal necrolysis.
Once again, for those at the back.
Toxic epidermal necrolysis.
Toxic epidermal necrolysis. Okay.
And there are it's rare. There are a few drugs that cause it: antibiotics, anticonvulsants, allopurinol, and a few others. And it evolves over the course of hours or a few days, and it's got quite a high mortality rate because essentially what happens is the surface of the skin dies off, full thickness epidermal loss.
Stop it.
And essentially acting like a burn, although there's no damage to the dermis. The dermis, where all the collagen and the elastic tissue is, has virtually no ability to kind of prevent infection. It's just wide open.
Yeah.
The epidermis is there to keep the outside out.
Absolutely.
And if that all sloughs off, then you are in peril. And this can evolve very rapidly over the course of a few hours. It's very painful. It's very characteristic in how it evolves.
Yeah. Oh, okay.
And there's not a huge amount that you can do about it other than keep people alive until it heals. You've got to identify the drug that's caused it. And if they're still taking it, you need to stop it. That's the one thing that influences mortality more than anything else. So finding out what the trigger is difficult because many people take loads of drugs.
Yeah.
You're looking for a drug that's been started within the previous 4 weeks to 2 weeks, that kind of interval, that kind of window. Yeah? Something that they started no more than a month ago, but probably no less than 2 weeks ago, unless they're given the same drug again, in which case it comes on within hours to days. And it evolves really quickly. So you've got to recognise it, you've got to get them in, you've got to keep them in as sterile environment as possible, you've got to replace the fluids that they're losing, you've got to monitor for infection. There is some evidence that you can treat with steroids or cyclosporin. Probably some of the new biologics have some effect, but that's risky because anything that suppresses the immune system also increases your risk of infection.
Yeah.
So that's a bit of a tightrope. So that happens really quickly. This is why I went to Paris. After I finished my training, before I became a consultant, I went to work in a hospital in Paris where they have specialised in dealing with this because it's so rare. Yeah. I saw a few cases as a trainee, and there were many more consultants than there were trainees. So usually it would be a different consultant responsible for the patient and then the same trainees seeing them all. And it was clear that there was a lot of confusion about how to look after them because if you don't see one for, if I'm not going to see the next one for 5 years, I'm going to forget what I did for the last one if it's 5 years down the line. Yeah. So in this hospital near Paris, they set up a centre where they would get them all from the region of Paris.
Wow.
So they had a constant supply of patients with this condition so they could get really good at looking after them. And they could also start to try to do trials on them. It's very difficult for a rare condition. And it's difficult to get consent from people. It's difficult to do double-blind trials in something that's evolving quickly and where people might die. So it's very difficult technically to do trials in people, which means that it's difficult to know what to do for the best, other than keeping them alive, monitoring them closely.
Crazy.
So I went out there, spent a few months out there, translated their regime from French into English and brought it back to Manchester. So at least we've got, an up-to-date idea.
Wow.
So that's probably the most frightening thing. The most frightening thing that I haven't seen is a condition called necrotizing fasciitis.
That sounds horrific.
Which is a kind of infection, a rampant infection where people become very ill very quickly. I've never seen it. I know a couple of colleagues who have. And I'm hoping that if I ever do see it, I recognise it because it evolves quickly. And they just need to be taken to theatre and have the necrotic tissue removed.
Of
Don't want
course.
to get too graphic.
Yeah,
But,
it's fine.
Big operations.
I am geeking out.
High mortality.
Of course. I mean, I can imagine knowing what those two words mean.
So it's always in the back of my mind, that little dread.
That you ever...
Am I going to see that? And if I do, am I going to recognise it and deal with it? But anyway, there you go.
That's fascinating. I think people will love that. I think people will love to listen. I think it's interesting to know what you're doing, what you're not doing, what you've seen, because they always ask about the best bits. Weirdly, it's a strange fascination. One thing that I do get asked about on a daily basis is I've got something we'll ring Kel, because I'm a skin person. I'm going through a bit of stress. Is this a stress rash? And it's very difficult to answer that question because it could be and it couldn't be. I know it sounds like two obvious answers, but like you say, you have to see it first. Quite often, if they're not stressed, it could be hormonal. It could be, what's your experience of stress and rashes?
Stress makes itch worse. Okay, itch is a very unpleasant sensation, and there's a reason for that. Like I said, going back several 100,000 years, it's the only way you're going to get rid of those parasites. So it's meant to be. It's meant to drive you a bit crazy. And the problem we've got now is that the skin, the permeability of the skin, the barrier function of the skin, I think is impaired, probably due to all the stuff we use, soaps and shower gels and stuff like that. So the barrier function of the skin becomes impaired. Things that shouldn't really bother us get in and irritate the skin. Okay? If you have this mild sensation of itch on the skin, you can probably, people ignore it during the day. People often say, I'm fine during the day, because they've got other things distracting them. And at night time, they've got nothing else to distract them. They're really scratching. If you get really stressed, that the hormonal changes, the mental changes mean you don't tolerate it as well. It's much more frustrating. It drives you that bit more crazy. So stress will often make rashes worse. Stress will often make the symptoms of rashes worse.
I mean, you get physical reaction, don't you, with stress as well? You get dilation.
And then occasionally stress does provoke people to do things to their skin, like dermatitis artifacta. So there are some conditions where I know that this is someone crying out for help, but taking it out on the skin. Okay. And you learn to recognise it in its various guises. Tackling that's difficult because they often they don't want to deal with their issues. They just want to create distraction.
Absolutely right.
And get help for that.
Of course. What's the simplest thing that somebody can do daily? You mentioned before that if it's dry, moisturise it. If it's wet, dry it out. You know, is there anywhere that people listening or you maybe want to come and see you or want to just do the bit of their own research can go? You know, do you have a Dr Nick Craven website?
I don't have a doctor. No, I don't actually. Maybe I should.
You should.
I'm getting a bit old for that kind of thing now. But the British Association of Dermatologists, BAD.
It's brilliant.
.org.
Brilliant site.
Has got loads of useful information on. There's DermNet.
NZ,
which is a New Zealand website. I will often use that during consultations because it's got great pictures of things. Often the problem is if you don't know what you've got, you don't know what to go and look up. So establishing the diagnosis is often the difficult bit. Dare I say it, artificial intelligence is probably getting better. You can often people will often come along and say that they've Googled it, but I suspect in many cases they're using artificial intelligence. And they've come up with a diagnosis that I agree with.
Right.
So I presume that these things are working more effectively now. But of course you don't know if you've got the right diagnosis from something you can't.
Very true.
You can't look in the eye. I think that's one thing that will save doctors from artificial intelligence is I think you've got to trust the person treating you.
True. Very true.
And I don't know how easy it is to trust a computer. I think it's easy. I think we're wired to either trust or distrust people that we meet.
Oh, are you kidding me?
So it's a lot easier than with computers.
I massively agree with that. I remember I spoke to a friend the other day and she'd said, I'm being gaslit by my AI bot because it's basically telling me, genuinely put in this idea, which was, I've got a piece of shit. It needs to be covered in glitter. And they were like, you were onto something. I was like, what? she was like, no, tell me. It's like a really rubbish piece of crap idea. But this AI was agreeing with me.
Right, okay.
Like, this is new, this is evolutionary. She was like, okay, what is happening?
Yeah.
Don't blow smoke. I need you to be honest with me. So
Program to please.
Oh my gosh, I think that we've got to be careful of that.
Yeah.
But yeah, AI is definitely moving into medicine.
Yeah.
Heavily.
Yeah, it's got to be. I think it's just got to be harnessed. It's got to be used.
I agree.
And, it'll take time to figure out how to use it. It'll take time to learn the pitfalls. And I don't know, does AI go back and have another think? Like a doctor would, hopefully, if they've said something and it's wrong, you go back, they'll hopefully think again. Or get, refer on for someone else. Get someone else involved. I don't know if AI is clever enough to do that.
Probably.
Maybe one day.
I mean, they're probably working on it right now. Elon probably is working on it.
Along with many other things.
Yeah. So what advice would you give an aesthetics practitioner thinking that they know what you know, or trying to have a go, or, that I'm lucky enough to have known you and know you and are able to refer out to you, and now you're private. I'm going to bring you even more on board.
It's fine by me.
Hopefully. But what advice would you give to practitioners? Would you say try and find a dermatologist and buddy up with them? Like what? Because it's really blurred.
It is. I think, first of all, if they're trying to do it on their own, I guess I would say use your common sense. Okay, if you're not sure what you're dealing with, you need to rely on common sense. Is it safe to experiment with things, or do you just need to hands up? I don't know what this is, and don't be afraid to refer on. And that's where it's good to have an idea of where your local dermatologists are if you're talking about skin things. So you can refer on, or maybe just send them a picture and say, look, do I need to worry about this? Sometimes you can tell from a picture. So someone that you may be able to hold hands, with. Yeah. And they may be able to help out looking at an image and saying, actually, yeah, that's easy. I know what that is.
Absolutely.
Don't worry about that. Or, crikey, stop what you're doing, send them in.
Yeah.
So, yeah, it is. It would be, I think, a good practice to understand your own limitations and buddy up with someone who can take it one step further.
100% agree with that. And now we've met again and back together again. We're going to stay together forever.
No pressure.
No, I was going to say no pressure. He's like trying to run for the door. Thank you so much for joining me today. It's been so interesting. I've been dying to get you on the couch. Sounds weird.
Okay.
It's all innuendos.
Still filming.
Honestly, I've been so nice to see you again properly outside of work.
It is nice to catch up.
It's lovely. I'd love you to come back again, but if you've got to wrap up one, what your experience was like here today and where you see yourself in the future, where are you still going to practice?
I will be practicing for a few years yet.
Okay,
I've got kids going through school and university who need funding. Yeah. So I will be, I guess I'd look to slowly wind down. I don't think I could work full pace and then suddenly stop. No, I wouldn't know what to do with myself. So it's going to be a gradual reduction. I reckon I'm going to carry on doing more of the same because I do love general dermatology. I do love going along to a clinic and you've got your follow-ups where hopefully you know what's happening because you've seen them before. Yeah. And then all the people coming in for the first time, no idea what they're turning up with. Could be anything. So it's always exciting. There's always new stuff. And I'd love it and I wouldn't want to change that.
Oh, that sounds
so there you go. More of the same.
More of the same. Will you still refer to me?
Yeah.
Why do you like referring to me?
Because you're very good at what you do.
Oh.
You're close to our patients.
Yeah.
Because I know that I can't do what you do. And if they need what you do, then you do it best.
That was a good note to end on, wasn't it? It's like I was fishing. Thank you so much. I've absolutely loved it.
It's been a pleasure.
Oh, good. I hope you've enjoyed it.
I have.
Good.
Yes, okay. I have. Very much. Thank you. Thank you for asking me.
Oh, well, please come back again when we're working together.
I certainly will.
Watch this space. Thank you, Nick. That's it for today's Barefaced Chat. Thank you so much for listening. If you've loved this conversation, make sure you follow, rate, and share. It really helps more people find us and join the conversation. I'll be back next week with another honest, unfiltered chat. Because skin isn't just skin. It's your story, and I'm here for it.